Hey everyone, welcome back to Med-Surg Knowledge Nuggets, where we take big nursing topics and break them down into manageable, test-friendly content. Today we're talking about asthma.
Our first lower airway disorder is asthma. So asthma is very common in this country. There are over 18 million people here that have asthma. And of that 18 million, 6 million of those are children. In adults, it's more common in women than men, and in children, it's more common in boys than girls. All right, so what's happening with asthma? So asthma is affecting the bronchial airways, not the alveoli. And it ends up with an airway obstruction and bronchial hyperresponsiveness. So what that means is there's constriction, contraction of those small airways, there's inflammation, and it is easily triggered to occur with inhaled irritants. So for a person that doesn't have asthma, if you walk by a building and maybe they're doing construction and you happen to inhale some of that dust, it won't really affect you. You'll kind of clear your throat and you'll be fine. A person with asthma, that same irritant will cause this hyper responsiveness, and then it'll cause the tightening of those smooth muscles. It'll cause inflammation and mucus production, and then you have an obstruction in your airway. Okay, so that is asthma. So asthma is intermittent, so that means it's not all the time. It comes and goes. You have flare-ups. It is reversible. So once you start it, you can stop it and reverse it. There's tightening of muscles around the surrounding airways, leads to airway obstruction and bronchial hyperresponsiveness. Type 1 hypersensitivity. Okay, so here's the pathway. You're going to get exposure to the trigger. That's going to trigger the inflammatory response. We already know that vasodilation and then increased capillary permeability is going to happen from that inflammatory response. It's going to lead to airway edema, mucus production, and that airway thickening and bronchial hyperresponsiveness. Okay, so don't move on from this slide until you know exactly what asthma is. All right, so here are some triggers. Irritants could be almost anything. Cigarette smoke, mold, pollen, dust, animal dander, pollution, exercise, pollen, bugs in the home, cold air, exercise, all kinds of things. Anger, okay, stress. Then we have our risk factors. So risk factors for asthma include family history, if you have frequent respiratory infections, eczema, and allergies that cause rhinitis is also a risk factor for asthma. So there is a link between eczema and asthma, but there's still studies and research being done on that, so nothing is confirmed. But a lot of people who have eczema also have asthma and vice versa. Many kids that have eczema will go on to develop asthma. Signs and symptoms. So after a person is exposed to a trigger, the patient will have signs and symptoms like wheezing, dyspnea, which is shortness of breath, coughing, increased sputum. They'll have an increased respiratory rate. They can experience agitation and anxiety. That is a result of hypoxia. You may have use of accessory muscles when they're breathing. They won't be able to lie flat. They'll have increased heart rate, anxiety, and decreased peak flow readings. A patient that's having an acute asthma attack will have the inability to speak in full sentences. So if you've ever heard somebody who's trying to talk after they ran a marathon, it kind of sounds like that. You just can't get the words out. You just can't breathe and talk at the same time. So how do we diagnose asthma? So the diagnosis and assessment of asthma includes a detailed patient history, pulmonary function test, chest x-ray, and pulse oximetry, and possibly ABGs. So the history, when you're gathering data from the patient, should include any childhood illnesses, family history of allergies or asthma, eczema, smoking history, and any exposure to like environmental triggers. So the patient should also provide information about how frequent they have these episodes, whether they were triggered by a specific activity or time of day or time of year, like summer, spring, fall, or if it's more in the morning or evening, stuff like that. And then also we should be asking the patient, what did they do to feel better? What made them feel worse? Chest x-ray should be done and sometimes needed to rule out other respiratory conditions that could mimic similar signs and symptoms. So here in the center of the slide, you see a peak flow meter. This is a handheld device that measures how well air moves out of the lungs. So during an asthma episode, the airways will narrow and constrict, and a peak flow meter can measure this narrowing hours, sometimes days before the patient even has an asthma symptom. So this can be really helpful in preventing a big acute asthma attack. So one of the most common and major tests of part of the pulmonary function testing is the FEV1, forced expiratory volume in 1 second. And for normal adults without asthma, it's 70% is the norm. So if you have a decrease in this FEV1 by 15 to 20%, than what's expected, then those patients are likely to have asthma. If those values improve after you give a bronchodilator by 12%, then it's diagnostic for asthma. So to put in perspective, you have a patient come in, they take this pulmonary function test, it shows that their FV1 is 50%. It's supposed to be 70%. So that's a 20% difference. So that's a clue that says, okay, you probably have asthma. If the patient is having an exacerbation or not, you can give a trial dose of a bronchodilator, do the test again, and if it improves by 12%, so it went from 50 to 62%, then we can confirm the patient has asthma. Okay, so that's what that means. When it comes to ABGs, so if a patient is having an asthma attack and it's early, so they just had the trigger and now they're having a hard time breathing, they're hyperventilating because they just can't get enough oxygen in their lungs. If you drew their blood and did an ABG, they're going to be in respiratory alkalosis. They're going to have low levels of carbon dioxide because they're hyperventilating and they keep breathing it all off. Okay, they're breathing it out. Once it becomes more severe, in a more severe asthma exacerbation or attack, then you'll eventually start having a really hard time breathing at all. So then you're going to be hanging on to carbon dioxide. So then you're going to be in respiratory acidosis. So you're going to have high levels of carbon dioxide. Now let's look at this asthma action plan. So this type of plan varies slightly from provider to provider, but this is a textbook example that they're giving you, so we're going to use this one. So this is really common in young kids who have asthma when they're at school, so that the school nurse and the parents know what to do if the patient or if the child starts to have an asthma attack. Okay, so if we look at this, we're looking at a green zone, yellow zone, and red zone. This is referring to the results of the peak flow meter reading. So the patient will find out what their baseline is, and then these little markers will mark the zones. So when the patient blows out into the peak flow meter, the small changes in that air amount, the air volume, will will determine which zone the patient is in. So if you're in the green zone and there's a little description here, you're not coughing, you're not wheezing, you're doing well, you don't need a short-acting beta antagonist. That is what SABA is. If you blow into the yellow zone, then your asthma is getting worse. These are some signs and symptoms you may have. You can do some activities, but not all of the activities you normally do. You have shortness of breath, etc., etc. So here you should take your SABA and your steroid. Red zone, again, this is full-blown asthma attack. You need your SABA and steroid. So it's pretty self-explanatory. You go through it. It's everybody that has asthma should have this type of action plan somewhere. Okay, so this is an overview of medications used to treat asthma. So you need to know that some are for rescue, some are long-term. So rescue meaning that when you're having an active asthma attack, these are the medications you're going to give. The long-term are medications that you take every day, routinely, not as needed, that will hopefully prevent an acute exacerbation from happening in the first place. So here we have our quick relief rescue medications. We have bronchodilators and anti-inflammatory medications. So the bronchodilators are short-acting, inhaled B2 agonists. Okay, this is like our albuterol. And we're going to call those SABAs. Okay, short-acting beta agonists, SABA. So if a patient's having an acute asthma attack, we're going to give a SABA. Then we have our long-term controller medications. So these are anti-inflammatory drugs and bronchodilators. So our anti-inflammatory drugs are inhaled or oral corticosteroids, and here are some examples. So you're not going to give this by itself, so during an acute asthma attack. Then we have bronchodilators down here. So we have long-acting, and methylxanthines, which is thiophyllene. So that's a LABA. These bronchodilators are LABAs. And so just remember that LABAs can only be used when you combine them with inhaled corticosteroids. Okay, so these are LABAs, but they work in combination with these. So for example, you have a patient who was diagnosed with asthma. They're going to give them a LABA and tell them to take these 2 puffs every day. And if you have an acute asthma attack, then you're going to take this SABA. This is the guidelines used by most providers on step 1, step 2, and as the the severity, like if it's not controlled, then they need to add another medication and so on. And this is just a visual of the relievers, which are the ones you use during an asthma attack, controllers, combinations, and preventers. You don't need to know this. Okay, so complication of asthma is status asthmaticus. So this is when it just doesn't stop despite what you do. You're giving the medication, you're giving the anti-inflammatories, the steroids, bronchodilators, and just nothing is working. So these patients will require intubation. And you want to look out for this, and you're going to see bronchospasm, inflammation. It could lead to a mucus plugging where there's actually a big mucus plug in the airway. Chest tightness, wheezing, dry cough, shortness of breath, severe respiratory distress. You're going to see that pulse ox very, very low. This can be life-threatening, so this is going to be a priority patient. So assessment-wise, this is just a little bit of information for you here. Different levels of asthma. Mild intermittent, mild persistent, moderate persistent, severe persistent. So if you're having asthma attacks twice a week, that's considered uncontrolled because you really shouldn't be having asthma attacks that frequently, especially because we have triggers. So a lot of those triggers we can control, we can anticipate, and we have these medications that can be taken every day that can help prevent these episodes. So anybody who's having very frequent asthma attacks need to be reevaluated because that is uncontrolled asthma. So teaching wise, we want to make sure they have an individualized asthma action plan. We want to tell them avoid your triggers, okay, whatever those may be. We want to teach pursed lip breathing, medication regimen, inhaled medication usage. So they should know which is their quick acting versus their long acting. They should know how to use a peak flow meter and what those values mean in relation to their asthma action plan. They should not smoke. Any respiratory, people shouldn't smoke in general, but any kind of respiratory condition paired up with smoking is not good. It's just going to make things worse. So if they are smoking, they should stop. And then we want to educate them on when they should call the provider. Any worsening shortness of breath, cyanosis, blue around the mouth, they need to call or seek medical attention. And then they need to know how to use these devices. So there is an aero chamber or a spacer, that's what this is. And then we have our inhaler here. So when you use an inhaler, you're going to take off the cap, you're going to shake it up. Patients should breathe, exhale as much as they can, and then they're going to breathe in, push down on the inhaler, and try to hold your breath for a count of 10 so that medication has a chance to be absorbed. After that, slowly breathe out. So that's how you use an inhaler. Then we have a spacer. So this spacer is commonly used with kids, or you can use it for adults too that may have a hard time following these directions or being able to coordinate pushing down on this and then breathing in and then, this whole step process. This makes it a little easier. So this spacer has a one-way valve here, right here, and you put your mouth on it right here, just like the picture. And You put the inhaler in on this little side. There's a hole. The inhaler fits nice and snug. So the idea is that you push down on the inhaler and the medication stays in the chamber. So you put your 2 puffs in there, and the patient puts their mouth here, one-way valve, and will take a big deep breath in, and they're able to get all of that medication without, without wasting it. Like sometimes when you do it this way, it comes out, or especially if it's a child, they didn't inhale at the right time, so a lot of the medication just stayed in the mouth. So that will prevent all this with this spacer. So when the patient is inhaling from this chamber, when they're taking out, sucking in that medication, they should do it slowly. They shouldn't, they shouldn't suck the air out so fast that it makes a noise, because that means that, they're doing it too fast. The medication, it's just not the way to do it. They should do it, take a big deep breath in, nice and slow. And then review box 26.2 in your textbook to give you more detailed step-by-step on how to use this MDI inhaler and the aero chamber. And then one more thing to note, when a patient is taking a medication, especially a corticosteroid in an inhaler form, after they take their puffs and they hold their breath for 10 seconds and they breathe it out, they should rinse their mouth, because that corticosteroid is a medication. It can stay in the mouth. It can actually cause fungus growth because it is a steroid. It can also cause tooth decay. So we want to make sure patients are rinsing their mouth after using their inhaler.
And we've reached our final knowledge nugget for asthma. So the main takeaways for this condition include teaching the patient how to use inhalers properly, how to avoid triggers, and to follow their asthma action plan. We want to make sure that the patients understand the difference between maintenance versus rescue medications. And we also want to assess for early signs of worsening asthma, which include wheezing, increased use of rescue inhalers, and decreased peak flow readings, and we want to make sure we intervene promptly to prevent respiratory distress. We also want to collaborate with respiratory therapists, providers, and their caregivers to make sure everybody's on the same page with medication compliance and follow-up, especially if a patient has been hospitalized or after an exacerbation. Thanks for watching. If this helped clarify things for you, make sure to like, comment, and subscribe for more Med-Surg knowledge nuggets just like this one. See you in the next video.